So the vestibular system, that's going to be involving also cranial nerve number 8, but in addition to that, it's going to be involving a different section of the inner ear. Right? We talked about the cochlea already and all the organs and structures within the cochlea. That's super important. Right? You unravel the cochlea and you can see different regions, like the distal regions correspond to low frequency sound, like lower end, versus more proximal to that oval window, more higher pitch sound, right? So that was the cochlea. Now we're going to talk about the vestibular section, which is going to be involving balance. Now, these are all the different types of things we're going to be discussing here in the vestibular system. We're going to talk about just the anatomy as well as the innervation. We're going to talk about some of the otolith organs, utricles and saccules. We're going to talk about doll's eyes and the vestibular ocular reflex. These are the types of tests that you use to see if a patient has some sort of either vestibular damage, or you can also use this when you're in the process of diagnosing brain death and looking at function of the brainstem. So these are different tests you can do. We're going to discuss nystagmus versus Meniere's disease. Nystagmus, which can be associated with lots of different conditions. Diseases, maybe even like a tumor, or even with intoxication. Different drugs can cause nystagmus, for example. Alcohol famously can cause nystagmus. And then Meniere's disease, basically you get vertigo, loss of balance, you get tinnitus, and then also you get some hearing reduction as well. We're going to talk about Calorex testing. This is another type of test that you do to be able to diagnose different types of brainstem lesions. And then we're going to discuss the how the thalamus comes into play in allowing for information from the vestibular system to be processed. So you have different types of movement. So you have translational movements. So that's like moving forward, moving backwards. You also have rotational movements, which are going to be, of course, turning, right? Turning your head left, turning your head right. You're going to have gravity coming into play, so you can see if your head's tilted in a certain direction, right? And then the labyrinths within the semicircular canals are where you find hair cells. So it's kind of similar to the cochlea, right? You have the inner hair cells and the outer hair cells within the cochlea. You also have hair cells in the semicircular canals. And those hair cells basically have a bunch of fluid within those semicircular canals. And whenever you move, the fluid is going to have inertia, right? And so whenever you move in one direction, the hair cells basically move in the opposite direction because of inertia. It's like, have you ever had something in a glass of water, like a speck of something or maybe a floater, and then you spin the glass around, but the speck stays in its place, right? That's exactly the same concept of what's going on within the semicircular canal. It's the inertia of the fluid that's within the labyrinth system. The type of fluids you have are going to be perilymph versus endolymph. Perilymph is going to be on the outside. Endolymph is going to be on the inside, as the name implies, pretty straightforward. And recall, these are all embedded within the skull. So these aren't actual like tubes or anything. These are portions of your skull that are shaped like passageways, shaped like tubes. So as you see the depiction whenever you look at a textbook of the vestibular system, it just looks like there's these really cool, structures, right? But these are all part of the bone. They're all embedded within bone. Utricles and saccules, those are going to be associated with translational movement. And so remember, translational movement, front and back, right, versus gravity, so head tilting. Semicircular canals are going to be associated with rotation. So if you rotate your head to the left, rotate to the right, that's going to be involving your semicircular canals. You also have ampulla. The ampulla are going to be structures at the bases of these semicircular canals. So if you see the semicircular canals over here, whenever you look at the very bottom of them, where they originate, that's where you have the ampulla. So it's kind of an area where you found the hair cells, right? Those hair cells are going to be found within the ampulla. And then again, you have endolymph, which is going to be allowing for hair cells to be moving in different directions, depending on tilt of the head, translational movement, etc. So we already talked about the two major fluid compartments, endolymph versus the perilymph. Perilymph is going to be on the outside, endolymph is going to be on the inside. And they're going to be associated with signals sent to cranial nerve 8, right? So the vestibular cochlear nerve, right? Vestibular portion is associated with all of these different canals. Now, again, this is very similar to the hair cells you find within your cochlea, right? They're going to have little tiny cilia that basically move in different directions, right? And then depending on which direction they move, they're going to be held by these little like springs, right? It's very similar to what we learned about in hearing. And whenever those springs move, you're going to see displacement and then ions being involved in the sensation of like position. So these are going to be displaced, which basically whenever they displace, they're going to turn into an action, electrical receptor potential, right? An action potential. Ions are going to be involved in this. If you have direction in one way, you're going to have depolarization. Direction in the opposite way is going to result in hyperpolarization. Exactly the same type of process you see in hearing. Now, with these are called kinocilia. So kinocilia, you're going to see whenever they're moved away. So whenever the tallest one moves away from all the smaller ones, that's when you have ions coming in, and that's when you get depolarization. Whenever the tallest kinocilia moves towards the smaller ones, all those channels close, and then you get hyperpolarization. There's a couple other structures too that are not super high yield. The striola that are going to be found in the saccules and the utricle. These are going to be different types of hair bundles that are going to polarize and depolarize in different manners. But it's not super high yield. I'm not going to go into too much detail for those guys. This stuff, however, is high yield. The crista, the copula, or the cupula. These structures are what allow for detection of movement, right? Whenever the endolymph moves in one direction, it's going to affect the cupula. So this is all part of the otolith organs. So otolith, these are like little tiny crystals. They're like little stones that you find within the utricle and the saccule. So these stones basically move in relation to different types of movements, like tilt, for example, as well as linear movement. So if you move forward, translational movement, these otoliths are going to move in the opposite direction, right? So you move forward, the otoliths move back, right, because of inertia. You tilt your head, gravity is going to allow the otoliths to move towards the side that you're tilting towards, right? And the macule is going to be the structure that houses the crista, so that's going to be this structure again. The crista is what moves back and forth depending on which way you're moving. There's a bunch of gel that's going to be surrounding these hair cells. So it's got a bunch of gelatinous layers. And in terms of these little crystals, these are all made of calcium carbonate. And so that's the part of the otoconia. Now, what else is going to go into through here? So I think we already went through all these different structures. The utricle macule, that's going to be responding to head tilting, right? The linear acceleration is opposite of the force that will be causing like deflection, right, of the otoconia. Like if you move forward, all these structures are going to move in the opposite direction, backwards. So we refer to this as equivalent acceleration. So we kind of already talked about all that stuff. Now, in terms of translational movement versus tilt, your brain is going to perceive them in similar ways, right? So if you tilt your head backwards, it's effectively the same as translational movement forwards. Right? Have you ever been in, I think it's in, God, I can't remember what it was, but it was like a ride that you can get into. It's like a spaceship type of thing, and you have like a TV screen in the front, and it shows you moving in a direction, and you kind of like feel like you're getting like pushed back into your seat because of like G-force. I think it's in like Universal Studios, or maybe one. Yeah, that's a little bit different. This has to do with like you're like in a spaceship and you feel like you're in a spaceship and the spaceship is going up and down and like left and right, but you feel like you're moving forward. But in reality, you're like in a giant like console that's going like tilting in different directions, right? Your brain perceives that as the same type of movement, right? Whether you're tilting your head versus moving forward. Your brain perceives it exactly the same way, but it has to be coupled with visual stimulation, right? Like if you're tilting your head, obviously you're tilting your head because your eyes are seeing that you're looking in different directions or your head's tilted in a different angle. Versus if you're moving forward, same exact type of thing. Your brain is going to perceive it in a similar way, but you can actually see if you're in a vehicle, for example, that you can see yourself moving forward. But long story short, they're going to result in the same type of receptor potential. Right? You're going to get the same type of electrical signal, but it all depends on the context of movement. Again, head tilt produces displacement similar to certain forms of acceleration. Now, there's going to be different types of effects. So there's transient hair bundle displacement. This is going to have to do with response to static tilting of the head. So if you tilt your head and you remain tilted, you're going to get a constant type of neuronal firing from that type of movement. So that's going to be due to certain movement, right? Certain head tilt, right? It's going to stimulate different types of neurons that are associated with different hair cells in your ear. So they're going to be tilt dependent. In other words, some neurons are going to fire more if you tilt in a certain direction, or some neurons are going to fire more when you tilt in a different direction, right? So it's going to be direction dependent. So here's a spike histogram basically that's showing all of that taking place, right? Some neurons are going to turn on when you tilt in a certain direction. Some neurons are going to turn off when you tilt in a different direction. So here's your angular acceleration associated with endolymph movement. Again, the endolymph is going to basically serve as a force of inertia, right? So whenever you move in one direction, it's going to basically push the cupula in the opposite direction, right? The endolymph is going to force those hair cells to move in a different direction. The kinocilium is going to be the tallest of those. And again, the kinocilium, that's, depending on the direction of the kinocilium, that's where you have the sensory input of movement, right? So if the kinocilium, the tallest one, moves in the opposite direction of all the shorter ones, then you get depolarization, and vice versa. Again, inertia is going to be the major aspect behind all this. So as this diagram shows, whenever you have some form of acceleration type movement, if it's in one direction, the endolymph moves in the opposite direction, displacing the cupula, right? Allowing for depolarization and sending signals to the vestibular system. So in other words, vestibular fibers are going to fire in different rates depending on what type of movement you're in. So it depends on the direction of the rotation. It also depends on acceleration versus deceleration. Right, so these are all going to respond to different types of movements. You also have the cupula endolymph system, which helps to basically smoothen out the effects of movement and perception of movement. So you have high frequency firing. You also have low frequency firing. So high frequency firing would be associated with the actual velocity versus acceleration would result in low frequency firing. And these are things that you can actually test in a clinical setting. So I'm going to show you guys in a little bit like doll's eyes gaze. That would be associated, it all plays in with how fast your head is moving, right? So if you move your head really fast, usually your eyes are going to stay focused on an object like far away in the room, right? Versus if you move slowly, like your eyes can move along with your head. So we'll talk about that in a little bit. All right, moving on. So the vestibular nerves. So you have a vestibular nerve ganglion. This is also referred to as Scarpa's ganglion. But for this class, we'll just keep it simple, vestibular nerve ganglion. So they have bipolar neurons. So remember, a lot of your afferent neurons are going to be bipolar neurons. You have the sensory receivers, right, in the periphery, and then you have the portion that connects to the central nervous system, right? So it's sending signals from the peripheral stimulation, right, afferent information coming in that can be routed to the central nervous system. So you have the distal process that's going to be communicating with all these structures within the vestibular system. So it's going to innervate the semicircular canals as well as those otolithic organs, right, the cupula, etc. And then that's distally. Then coming into the central nervous system, you're going to have synapsing with the vestibular nuclei. So that goes directly to the cerebellum. Now remember, the cerebellum, one of the major roles that it plays is for smoothing out movement, but also for maintaining balance, right? This is really important for you to be able to perceive balance. If anything here goes awry, you can start experiencing vertigo, right? And vertigo, you can get vertigo if you have cerebellar damage. You can also get vertigo if you have inner ear damage, right? That's because all these systems communicate with each other. So here are a couple other things that are important. So optic flow, this is associated with the actual visual patterns, right? Like if you're actually moving in a vehicle, this is why it's important for context. Your eyes are going to help to basically regulate your sensory perception of those types of movements, whether it's a type of translational movement, moving forward versus just tilting, right? Just moving in a different angle. So context is going to be important, right? Your eyes are going to be important for that. The other thing that's going to be important as well is that vestibular ocular reflex, right? This is the doll's eyes gaze. So I'm going to play you a video of that in a second. Effectively, this allows you to maintain a steady vision, right? Steady focus on an object, even if your head is moving, right? So this is all involving the vestibular system, which communicates eventually with the extraocular muscles in the eyes. So here's doll's eyes. So this is a really good video that basically describes, oh, sorry about that. So the narrator does a really good job in describing how the extraocular muscles in the eyes are going to be communicating with the vestibular system. So good stuff. Let's watch it.
The doll's eye test is used to confirm function of the vestibular ocular reflex, VOR, of the brainstem in a comatose patient. If the brainstem is intact and the head is turned to the left, the eyes move to the right. If the brainstem is intact and the head is turned to the right, the eyes move to the left. Let's review the VOR pathway to understand how this reflex operates in response to an abrupt head turn. If the head is turned to the left, the horizontal semicircular canals, which are fixed in the temporal bone, rotate in the same direction. Due to inertia, the endolymph, the fluid within the semicircular canals, lags in the opposite direction. This increases signaling from the ampulla of the left semicircular canal to the left vestibular nucleus, and decreases signaling from the ampulla of the right semicircular canal to the right vestibular nucleus. Ultimately, by connections with the abducens and oculomotor nuclei, this results in contraction of the medial rectus on the left and the lateral rectus on the right, which turns the eyes to the right, that is, in the opposite direction of the head movement. If the head is turned to the right, the horizontal semicircular canals rotate in the same direction, and endolymph lags in the opposite direction. Signaling to the vestibular nucleus on the right is increased, while signaling to the vestibular nucleus on the left is decreased. Ultimately, this results in contraction of the medial rectus on the right and the lateral rectus on the left, which turns the eyes to the left, the opposite direction to the head movement. The presence of this doll's eye sign in a comatose patient is a good thing. The absence of a doll's eye sign would indicate brainstem dysfunction. Instant neuro.
So when I know that you wanted to learn more about how you diagnose brain depth, brain death, because that's one of the stories that I always tell. Is one of the things that turned me off about neuro is like literally diagnosing brain death on a patient. And if you do, like, you could be comatose, right, but you still have brainstem function, right? But if you're brain dead, your brainstem ain't working, right? And so that whole entire process is not going to function whatsoever. So that's why when a person is brain dead, their eyes are just literally going to be stuck in one position. It's regardless, right? And so that's fixed doll's eyes, fixed gaze.
I have a question before I forget.
Yeah.
If there's a tumor on the optic chiasm, what do we say happens?
Oh, you're going to see bitemporal hemianopsia. So you're going to have visual field loss on the lateral sides. Yeah, peripheral visual loss. Yeah, so optic chiasm. Yeah, no sweat.
I don't know if that was for patho or if it was for this class. But
I teach that in every single class. Whenever I talk about the pituitary gland at all, I'll mention that, because it's one of the signs and symptoms of a pituitary adenoma. Is you'll start getting like it'll start impinging upon the optic chiasm, and that's one of the hallmarks. Is I'm starting to like get my visual field deficits laterally, right, peripheral vision. So here's optic flow. This is how you detect whether or not you're moving, right, in motion. So this helps to communicate with your vestibular system. This is also something that could be processed by your brain. Is, if you're wearing glasses, for example, glasses is going to result in this similar type of effect, right? So it's going to, you get like that whole vestibular ocular reflex. Right? If you're wearing glasses, you take it off and you can kind of see the change in focus. That's going to communicate with your vestibular system as well. So here's that pathway of moving your eyes, right? Stabilizing the eyes. This is one of the reasons as well, like if you're jogging and you're running, your eyes, you're able to still see really well. Some animals don't really have a good, they're not really able to do this very well. So whenever they run, they might not be able to see very well. Whereas for us, when we're running, we're able to see really well, because even though our head's moving all over the place, right? It's not like your field of vision is just rattling around, right? It's all being stabilized. And this is the whole process that's stabilizing that. So here's the pathway. So we're going to go into the vestibular ganglion, Scarpa's ganglion. It goes to the middle vestibular nucleus. So here's the ganglion, right? So then it's going to go to the middle vestibular nucleus, and then the signals are going to be sent up to the different extraocular muscles in the eyes. So you have inhibitory and excitatory effects on the abducens nuclei. So it'll affect the abducens nerve, depending on which eye you want to turn on and which one you want to turn off. You also have the medial longitudinal fasciculus that's going to be involved in this process too. That's going to communicate with the ocular motor nucleus, cranial nerve 3, and that's going to affect, again, your other extraocular muscles, medial rectus and your lateral rectus. So when the medial rectus is stimulated, that allows for inward eye movement, right? Lateral rectus allows for lateral eye movement. And so cranial nerve 3 is going to innervate the medial rectus. Remember, your lateral rectus is going to be cranial nerve 6, or your abducens nerve, so that you can look away. So be familiar, whenever you have a functioning vestibular ocular reflex, you tilt your head to the right, your eyes move to the left. So they basically move in the opposite direction. And then the opposite is also true. Okay, moving on. So the circuit moves the eyes to the right, so away from the horizontal canal. It's when the head moves to the left, right? So the eyes are going to be moving in opposite direction from each other. And just know that be familiar with the cranial nerves that are being involved in this. I'm not going to test you on the individual nuclei, by the way. I'm not going to test you on the medial longitudinal fasciculus. I'm not going to test you on the ocular motor nucleus or the vestibular nucleus. But be familiar with the cranial nerves, right? Be familiar with the cranial nerves, which muscles that they innervate. So say, for example, you move your head to the right, which of the nerves are going to be turned on and inhibited, right? Innervating the extraocular muscles in the eyes. So those might be fair game type questions for the last exam in this class. Okay, moving on. All right, now let's talk about nystagmus as well as Meniere's disease. There's two types of nystagmus. There's going to be a physiological nystagmus, and you can also kind of think about this as being associated with that vestibular ocular reflex, right? This is like your eyes adjusting to the movements of your head so that you can still maintain focus on an object that you're looking at. Spontaneous nystagmus, on the other hand, it's your eyes moving side to side, and that doesn't have to do with your head moving. So in absence of your head moving, if you get spontaneous nystagmus, that's what we're talking about, right? The head is not moving. An example of nystagmus that could be normal, because nystagmus can be normal. If you're in a train or a moving vehicle and you're just looking out the window and you're just like seeing objects move, right, as you're traveling along, right, you're going to get nystagmus. So that's normal. Otherwise, if it's abnormal, you might be intoxicated, right? So that's one of the tests that they use for like a field sobriety test. Follow the finger. The cop asks you to follow the finger. If you start seeing your eyes jittering, you're probably intoxicated. Meniere's disease is something else. Meniere's disease is where you have too much fluid in the vestibular system, so too much endolymph. Now, the results of that will be vertigo, so you feel like the world is spinning around you. Tinnitus is another thing too. That's that ringing in your ears, right? You're hearing a constant buzzing sound in your ears. And you can also feel pressure as well. Let's go ahead and watch a video about Meniere's disease. Whoops.
Meniere's disease is a long-term inner ear disorder that causes recurrent attacks of vertigo and symptoms of hearing loss, tinnitus, and a feeling of fullness in the ear. A top tip for you: remember the typical triad of symptoms in Meniere's disease, as this is commonly tested in exams. And these three symptoms are hearing loss, vertigo, and tinnitus. Let's start with the pathophysiology. Meniere's disease is associated with the excessive buildup of endolymph in the labyrinth of the inner ear, which causes a higher pressure than normal within the labyrinth and disrupts the sensory signals. This increased pressure of the endolymph is called endolymphatic hydrops. So what's the presentation? The typical patient is 40 to 50 years old, presenting with unilateral episodes of vertigo, hearing loss, and tinnitus. Vertigo in Meniere's disease comes in episodes. These last for 20 minutes to several hours before they settle. These episodes can come in clusters over several weeks, followed by prolonged periods, often months, without vertigo symptoms. Vertigo is not triggered by movement or posture in Meniere's disease. The hearing loss in Meniere's disease typically fluctuates at first, associated with the vertigo attacks, then gradually it becomes more permanent. It is a sensory neural hearing loss, generally unilateral, and it affects the lower frequencies first. Tinnitus initially occurs with episodes of vertigo before eventually becoming more permanent, along with the hearing loss. And this is also usually unilateral. Other symptoms with Meniere's disease can include a sensation of fullness in the ear, unexplained falls or drop attacks without any loss of consciousness, and imbalance. And the imbalance can persist after the episodes of vertigo have resolved. Spontaneous nystagmus, which is where the eyes rapidly flick side to side, may be seen during an acute attack of vertigo. This is usually in only one direction, or unidirectional. So how do you make a diagnosis? The diagnosis of Meniere's disease is clinical based on the signs and symptoms. The diagnosis will be made by an ear, nose and throat or ENT specialist. Patients will need an audiology assessment to evaluate their hearing loss. The audiogram will show a sensory neural pattern, unilateral and affecting the lower frequencies first. Let's talk about management. Management involves managing symptoms during an acute attack and prophylactic medication to reduce the frequency of the attacks. For acute attacks, the short-term options for managing symptoms include prochlorperazine or antihistamines, for example, cyclizine, cinnarizine, and promethazine.
So long story short, drugs that are going to help minimize the amount of fluid accumulation within the ear. So all these drugs can help to minimize fluid production, right? Especially antihistamines, right? One of the key things that antihistamines do, they reduce fluid production, right? That's why it's used to treat allergies, for example. So that's Meniere's disease in a nutshell. Now, in terms of physiological nystagmus, this has to do with moving of the head, right? This is different than spontaneous nystagmus. So when you move the head, the vestibular fluids within the horizontal semicircular canals are going to move. So in this case, it looks like they're rotating her head to the right side. And then you're going to see nystagmus and eye movements coming into play here in different ways. So you have a slow eye movement and then you have a fast eye movement. Now, these are two different types of nystagmus, right? When you're moving your head to the right, you're going to see a slow eye movement to the opposite direction. And then the fast eye movement is going to be in the same direction of your movement. So this is also something that you can test using a caloric testing exam. Now with caloric testing, why do we call it caloric testing? Because calor means heat. And so you're actually manipulating the temperature within the ear. And the guy who came up with this whole entire diagnostic tool, I think he won the Nobel Prize for this. So really interesting stuff. And this type of testing in a clinical setting can actually allow you to diagnose different types of brainstem lesions and to even see if the brainstem's functioning whatsoever. So you can do this caloric testing in that comatose patient to see if they truly are brain dead or if they still have some sort of function within their brainstem. Now, the mnemonic that's really useful for this is COWS, because even though caloric, we're using heat, you're also using cold too. Now, COWS, it's cold and opposite. And then with W, that's warm, and then the movement is going to be towards the same direction. And when you say opposite, it's away from the ear that you're injecting the either cold water or air. They can use air as well. So if you're getting a normal read, right, the slow eye movement is going to be towards the irrigated ear, okay, and fast is going to be away from it. So with cold, you're going to get movement away from the ear. That's going to be the fast type of movement. Versus warm is going to be at the same side. So I'm going to play a video of that in a second, but before I play the video, let's look at the schematic of normal. So here's the ocular reflex. This is a normal individual. They're conscious, right? They don't have they're not comatose. There's no brainstem lesions. So if you put in one ear, so for this person, it's going to be in their right ear. So you're putting cold air in there. The fast movement is going to be going away from the cold air, but then the fast movement is going to be in the same direction as where the cold air or water is going into. Versus warm, when you're putting warm air or water into the right ear, the fast movement is going to be in the same direction as the stimulus, versus the slow movement is going to be in the opposite direction of the stimulus. So that's in a normal functioning individual. Everyone over here, these are all comatose patients. This one over here is where the brainstem is actually still functioning. So if you put cold air into a patient that has an intact brainstem, they're not going to have any of the fast movement. So they're not going to have fast nystagmus. They're only going to have the slow movement. And the slow movement is going to go towards the cold, versus putting warm air or water, you're going to have only slow away. Okay? Slow away. Now, if you had a medial lateral fasciculus lesion, that's what MLF is, medial longitudinal fasciculus damage, you're going to get only one eye is going to move, right? So one eye on the right side, right? If you have cold stimulus, only the right eye is going to move. And then for the warm air or water, only the left eye is going to move slowly away. And then this is where you have a brainstem lesion where the brainstem is no longer intact. You're not going to get any sort of effect whatsoever, right? So if you're diagnosing brain death, you do the doll's eyes gaze to see the vestibular ocular reflex, right? And then you can also do caloric testing, injecting cold water or warm water into the ear. So it's amazing to think that a guy won a Nobel Prize for basically giving somebody a wet willy. So let's watch a video on this clinical application, caloric testing.
Instant neuro. Caloric testing is used to confirm function of the vestibular ocular reflex, VOR, of the brainstem in a comatose patient. Let's review the VOR pathway to understand how this reflex operates in response to caloric testing when the brainstem is intact. For the purposes of this video, we will only observe caloric testing for the right ear. Placing cold water in the right ear leads to decreased signaling from the ampulla of the right semicircular canal to the right vestibular nucleus. Ultimately, by connections with the abducens and oculomotor nuclei, this results in contraction of the medial rectus on the left and the lateral rectus on the right, which turns the eyes to the right, that is, towards the cold water. An absence of this response would indicate brain dysfunction. Placing warm water in the right ear leads to increased signaling from the ampulla of the right semicircular canal to the right vestibular nucleus. Ultimately, via connections with the abducens and oculomotor nuclei, this results in contraction of the medial rectus on the right and the lateral rectus on the left, which turns the eyes to the left, that is, away from the warm water. An absence of this response would indicate brainstem dysfunction. Recall that the mnemonic COWS can help you to remember the direction of the fast component of a nystagmus. However, since our patient is in a coma, there is only the slow component, the pursuit, the VOR reflex, as the fast component, the saccade, requires higher cognitive function. Instant neuro.
So that's where the COWS mnemonic will actually help. It's only under normal conditions. So the patient's actually awake, alert, and their brainstem is working fine, then COWS would be the mnemonic for you to pay attention to. Otherwise, you're not going to get that fast component. So COWS is only for fast, right? Cold, fast, opposite, right? Warm, fast, same, okay? All right, let's watch another video on, this one's a short one.
So let's take a look at what this response looks like and how it's done.
In this case, they're using air, right? You can use water for this, but you can also use air as well. It will elicit the same type of reaction.
We'll be doing a test on Sarah's left ear using warm air. The air goes into the ear for 1 minute, and during that minute, she may start to feel a sense of dizziness. During that time, we may also start to see some eye movements or nystagmus on our computer screen. At the end of 1 minute, we'll continue to record, This is considered to be the peak of the response. And so in this situation, the patient may feel some dizziness. How are you feeling?
Kind of dizzy.
Very good. That's completely normal. We fully expect there to be some dizziness with this task. That tells me that the ear is working as it's supposed to, and that we're getting a good response from the ear. And in just a few seconds, I'll turn on a dot to help Sarah come down from that sense of motion. That helps to stabilize the eyes and bring her back to the baseline. And from here, we've reached 2 minutes of recording.
Okay, so that gives you an example of how this type of testing would be done in a clinical setting. But like I said, this is like for a normal patient. This type of testing is also going to be done in like the ICU, right? When you're dealing with brain dead patients who are comatose. And here's a really good chart that basically shows you all sorts of different types of effects. I'm not going to test you on all this. So if you're familiar with brainstem intact, I might test you on a medial longitudinal fasciculus lesion, maybe. Definitely know your no brainstem function. You definitely know what that would look like, right? It's pretty obvious, but make sure you know brainstem intact, comatose. Also know normal, right? What happens under normal circumstances. So in other words, if you know normal brainstem intact and low brainstem lesion, maybe MLF lesion, then you should be good. All this other stuff is just like extra. I thought would be kind of interesting for you guys if you're interested in that kind of stuff. All right. So posture and equilibrium. So posture, equilibrium, again, note cerebellum is going to be heavily involved in this, right? Cerebellum helps to maintain your posture, but it also communicates with those regions in your inner ear. So you have the vestibular cervical reflex and the vestibular spinal reflex. There's different regions of the brainstem that are going to be associated with that. You got for the vestibular cervical, you're going to see vestibular nucleus communicating with the medial longitudinal fasciculus, whereas the medial vestibular nucleus, which eventually communicates with the where is that? The lateral and medial ventral horn. This is going to be more for like the limbs. Right, so you have one that's going to be associated with your head and neck, and you're going to have one that's going to be associated with your limbs and the position of your limbs in like three-dimensional space. I'm not going to test you on these specific regions of the brain, right, the different nuclei, but head reflex, this is going to be associated with your semicircular canal, and then you have your lateral vestibular nucleus associated with limbs, right? So medial vestibular nucleus is going to be head reflex, right? Position of your head versus your limbs, the rest of your body, that's going to be your lateral vestibular nucleus. But like I said, I'm not going to test you on those. This is FYI if you want to learn about movement in different animals. So like fish, for example, are also going to have reflexes to alert them to danger so they can rapidly move away from danger. And it's going to be due to all sorts of different types of chemical signals and the approach of predators, for example. And this is pretty rapid, so it's going to be involving electrical synapses. This is the Mouthner's cell reflex in fish, but I'm not going to hold you guys responsible for that. I'm not going to go into any details any further on the fish reflex. So vestibular cerebellar pathway. Again, this is going to be associated with your vestibular ocular reflex, right? Distinguishing tilt from translational movement, to summarize. Distinguishing passive movements of the head versus those that are self-generated, right? The thalamus is also going to come into play here as well. So the thalamus is going to be, again, a relay center for a lot of your incoming afferent information. And so the thalamus is going to help communicate those afferent input into cortical regions so that the cortical regions can help to basically process all that information. So moving through here. Now, in terms of higher order vestibular perception, so when you talk about higher order, we're talking about the cortex, right? The cerebral cortex is, ultimately going to help to process the data that's coming from the cerebellum as well as the brainstem. So you have basically conscious perception of orientation, right? So in other words, the cortex is going to allow for conscious perception of movement, posture, etc. Acceleration, head tilt, and all the above. So we have a few minutes left. Let's just go ahead and log in, do one quizzes question on here. If we have time, maybe we'll get into part 3, or we could reserve that for next week. It's up to you guys. So we'll do like a couple of questions here, and then we'll move into part 3 maybe next week. Do you guys want to do that instead? All right, awesome.
Really quickly, what was it that you said about the thalamus?
The thalamus is just a relay center, right? I'm not going to hold you accountable for the entire pathway involving the thalamus, but a lot of your sensory data just gets processed through the thalamus. The only thing that doesn't get processed through the thalamus is olfaction.
Because that goes straight to the...
Yeah.
Is that what we're doing next week? That's how you put that in the...
Next week, we're going to do olfaction. Yep. Yeah, we're going to do olfaction and taste. So olfaction, we have 50 slides to go through. Taste, it's so far about 50 as well. So hopefully we can get through those both in one lecture, because we need to start getting into motor function as well. So what condition is that? Vertigo, hearing loss, tinnitus, Meniere's disease. Yeah, Meniere's disease. What's the underlying cause of Meniere's? Most of you guys got it correct. So excessive buildup of fluid in the inner ear. This is not associated with infection of the inner ear, right? Although you would get buildup within the inner ear, the middle ear, but it wouldn't necessarily affect the inner ear. So if the inner ear gets affected, that's Meniere's disease. Wait, what? Oh, I only made one question. I didn't finish this quizzes question. So let me actually finish these over the weekend. I'll write you a bunch of practice questions, and that's how we'll start lecture next time. We'll go through a couple more practice questions.